Okay? Okay.
Assalamu alaikum. I would like to ask the next speaker to come to the stage. Dr. Mohamed Al Deeb is our next speaker. He has a doctorate in degree in cardiology since 2002, and he's a fellow of American Cardiology. He's a senior consultant intervention cardiologist and head of cardiology unit at Al Hayat International Hospital. And the topic will be cardiorenal syndrome update.
Hi, good morning. Assalamu alaikum. A bit updating the title, which is the program regarding the heart failure. So let us go above the diaphragm. I'm like a foreign organism here. But in the beginning, I want, of course, to thank the organizers, especially my old friend, Raisa, be here. And I think in the next conferences, I think more cardiologists should be here and more nephrologists should be in our conference. So let us start by this. This is two public health authors in 1996 put the heart failure in the Cinderella of cardiology. And why they put the Cinderella of cardiology? Because that time, most of the interest was going toward cardiac infarction, but very less was heart failure. Now, in 2023, I think the heart failure is not anymore Cinderella among the cardiologists. So there is, especially after the RNA and after the flowsing, the heart failure research and heart failure medications and devices making really heart failure is to be one of the top interests in many of the cardiologists. Unfortunately, still of many of the health authorities, here and all over the world, heart failure is still a Cinderella. And surprisingly, they can put hundreds of thousands of reals or dollars for cancer just to prolong the patient of 3 months. But for heart failure, they said we need a protocol, we need priorities, which patient to take RNA, which patient to take the gliflozins, and all of these dilemmas. Even among the public, still heart failure is a Cinderella. If a young lady should develop dilated cardiomyopathy with ejection fraction 20%, she will not take even attention from her family if she is get cancer breast, although she will die from heart failure much earlier than the cancer breast. But the other Cinderella which came is the kidney and the cardiovascular system. And many cardiologists will think that kidney is important, but the importance of the kidney is underestimated among many cardiologists. I think, again, many of the cardiologists now, they are realizing that without the kidney, they cannot go. But unfortunately, still many physicians, kidney is a Cinderella for the cardiovascular system. So the main aim of the talk is just without the kidney, you cannot go. We will see now, without the kidney, you cannot go anywhere in the management of heart failure. So putting the horse behind is not going to make anything, because 3 pillars of the 4 pillars of the heart failure, you cannot go and you cannot prescribe without knowing the EGFR. So you cannot go here even 5 meters with the heart failure patient without knowing his EGFR. So the kidney first in cardiology, I think kidney before anything. The only exception that I can go without knowing the EGFR, if the patient coming with for STEMI with primary angioplasty, will take the patient maybe to the lab before the kidney function will come. And of course, if the kidney function is EGFR is 20 with the patient on table and are going to give him contrast, is a very, very bad news, but you cannot have any other option. So heart failure, chronic kidney disease is the most prevalent comorbidity with patients with heart failure. And when both on board, this is the highest ever mortality, highest ever hospitalization. But see the paradox. Despite this high mortality, high hospitalization, patients with kidney disease are the least of giving them the guideline-directed medical therapy. So this is a very nice movie, The Double Jeopardy. And this movie, The Double Jeopardy, is regarding this. Murder is not always a crime. And a cardiologist and nephrologist is doing this crime every day. Because despite the worst prognosis with patients with heart failure and CKD, most of these patients may only be in beta blocker and nothing else. So I understand the dilemma, and the dilemma that most of the patients with EGFR, less than 30% was excluded from trials. And if you go here from the SAVE in 1992 up to the embryo preserved in 2021, ejection fraction, the EGFR less than 30 was all excluded. So from Bill Clinton, this is Bill Clinton in the stair of the Air Force One in 1992, where the safe was captopril was launched at that time, to Biden now in the, again, the stair of the Air Force One in 2021. It is still the same, and the same is the kidney should be out. So this is a big problem because you cannot have a very good evidence to direct for the patient with EGFR less than 30%. We are the cardiologists. This is our definition for the 25% increase creatinine, 20% increase in the EGFR to divide what's called the WRF. So the incidence among your patients, not my patients, is 17 to 21% of your patients will develop heart failure. Among my patients, 55% of my patients have some sort of impaired EGFR. Very, very, very rare now to see EGFR in more than 90 in such patients. So most of the EGFR, it will be in the lower side. But the problem is, the big problem is, as you may have a big misconception of this with increasing the disease of the kidney, there is increasing in the incidence of the heart failure up to 44 in the EGFR. This is again is the misconception that the dialysis actually have less heart failure. No. It is a big problem, the dialysis patients having more heart failure. Let us go for the diagnosis. If we go for the 2021, the AEC, this is European Society of Cardiology Guidelines of Heart Failure. They put the clinical number 1, the BMB number 2. If you go for the American, they have the same. So what is the problem here with kidney patients? The fatigue, the dyspnea, the swelling, the lower limb swelling, and all of this, very common in kidney. So I swear no one here can diagnose heart failure accurately in patients with kidney just because my clinical experience. This is error by gun. There is no clinical examination here that give you really a clue if this patient having heart failure or not. The other problem that pro-BNP is increased in patients with CKD. But luckily, unfortunately, up to 30% you can go ahead. But I want to raise something important here because you can see a patient coming to the emergency, his troponin is 100. Oh, it is kidney disease. So what is kidney disease? His troponin is 100. Yes, but it's kidney disease. So the issues that take casual, the kidney and pro-BNP, the troponin and pro-BNP high, or the biomarkers are in kidney disease, it is a marker of force prognosis. It is a marker, maybe not necessarily to be heart failure, maybe not necessarily to be ACS, but take care these patients, your patients are at increasing risk. However, as I said, luckily that as long as the EGFR is above 30, you can use the same numbers as the cardiology are using. So up to stage 4, you can use. The dilemma is in hemodialysis. Again, hemodialysis is a big problem with heart failure because in such patient prevalence is 44. In such patient, you cannot use the pro-BNP for the diagnosis, but you can use only for prognosis. So these numbers which used in the guidelines is still valid if you use anti-pro-BNP. And I think any one of you, please use only one. Don't be, so one center use, I'm going to use for the anti-pro-BNP. I don't look now for the BNP, I don't know the numbers. So for 125, 300 for the patient hospitalized. If the patient coming in the emergency, 450 for less than 50, 50 to 75, it is 900, and then 1,800 for the diagnosis. So this is a problem with the diagnosis of heart failure. Someone will say, what is the rubbish you are doing? Why, where is the echo? What is the echo? Okay, Habibi, patients on hemodialysis who did echo ejection fraction 60%. Is he having heart failure or not? We don't know. It may be HFpEF, it may be the pro-BNP is high. So it is a real dilemma. I don't underestimate the issue of the first two. This is currently in 2023, the 4 pillars for the management of heart failure, SGLT2 inhibitors, the ACE-ARNI, and ARNI is the interest of someone, most of you are non-cardiologists, of course, the beta blocker and the MRA. This is very important slide. This is very important slide. If you go on the right here, for example, you can see that the ACE, the ARNI, the ARB, and even the SGLT2 inhibitors will do efferent vasodilatation. This will decrease the EGFR. This is how this medication works. So if the EGFR will decrease in the beginning, this is how this medication works. On the other hand, also the SGLT2 inhibitors and the loop diuretics will do efferent vasoconstriction, and this is how the medication works. So for example, the SGLT2 inhibitors will hit the efferent vasoconstriction, vasodilatation, and the efferent vasoconstriction will decrease the EGFR in the beginning. So if you are not aware of this, you will be scared and you will not go ahead at all with your patient. But all of the medication at the end will increase the cardiac output, will increase the renal blood flow, and may increase the eGFR at the end. So this was a question, and I think all of you, the old people like Isa and me, was very sensitive. The nephrologist, when we started 15, 17 years back, when the nephrologist will come and he will see ACE-ARB in the medication, what is the first action? Stop ACE-ARB. Habibi, stop ACE-ARB. That time, there was no evidence that we are having now. And this question is a history now. And they claim now that because of if you stop, you may increase the need, the time need for the dialysis. You may, if the patient having any infection, may not need any deterioration. But now there is, despite all what's happening there, of a lot of observational studies that tell you don't stop, there are still many people stop. And all of us was waiting for one firm issue, and the confirmation all of us was waiting for the Stop ACE trial. And the Stop ACE trial in December 22 make it very clear. Don't stop. No patients will not go faster for dialysis if you're going to use ACE and ARB, but the patient will die from the cardiovascular. So this question is a history. We means both together now, we should be sustained the decrease in the eGFR in the beginning. So this issue solved. Now come to, I will put just a very simple algorithm, and I like this algorithm now, how to treat a heart failure as a nephrologist in heart failure patient. I'm saying about the HIF-REF. If the patient is eGFR more than 60, the 4 pillars import. You should start everything. The 4 should be started. You repeat the eGFR after 3 weeks. And mainly to look, we know the eGFR may decline with SGLT2 inhibitors. It may come down with the ARNI. So the early dip in the management, you should concentrate in the 3 weeks for this. This is if the eGFR is at 60. If between 3 to 60, take the spironolactone out in the beginning. Take the spironolactone, don't start spironolactone. When I will start spironolactone? After 2 weeks. If after 2 weeks there is no more decline in the eGFR and the potassium is still less than 5, now you can put the 4th pillar here. This is between 30 to 60. Now, if you between 50 to 30, take the ARNI out and take the MRA out, and just the SGLT inhibitor with the beta blocker. Again, when the ARNI will come, again after 2 weeks. If you sustain the early dip from the SGLT inhibitor, you make a small dose of ARNI inside, up to 25 twice daily from the interest to here. Now, what about the ejection fraction? This is 15%. This is low dose beta blocker, low dose ARNI. 25 BD, 50 BD, lisinopril 5, Divan 40 BD, very small dose, and don't up-titrate in such patients. We are at the edge with these patients. The evidence, of course, is very little for these patients. This is the why in this one. We took the aldactone at eGFR less than 30 to 60, why we took it less than 30 for the ARNI, why we took it less than 15 with the SGLT inhibitors. This is a very nice observational, and I will just go there. A better renal function profile emerged when sacubitril valsartan was added to EMBA. Look here, please, from here. If you give the EMBA first, the empagliflozin will do the efferent vasoconstriction, the efferent vasodilatation, and the eGFR will decrease. If you give the EMBA first, then the EMBA will do first the vasodilatation and the vasoconstriction. When you add the ARNI, then it will be better for this. So the issue is, if you use the EMBA first, you prepare the kidney for the ARNI. This is how to make it. That's why in the eGFR between 15 to 30, we said put the gliflozins. Put the gliflozin with the beta blocker, wait for the eGFR. If you sustain you and the patient have the eGFR, you put the ARNI after this. So this is my suggested algorithm for the use of ACE and ARB. If you are still using this medication, I am not using these medications anymore. But if increase in the serum creatinine less than 30%, go ahead, Habibi. Don't worry, continue. Don't do anything. But if it is between now 30 to 50%, or now, but creatinine is still less than 26, the AGFR less than 25, continue rest. Continue rest? Yes. And then repeat the AGFR. If it's not improving, now you should decrease by 50%, or even you stop later if it's not improving. Now, what about if it is more than 50%? Haram here. Don't do anything, and don't add S and R here. This is regarding this one. If you still now doing this is HIF-RIF patients. All what I said about HIF-RIF patients. What about HIF-RIF patients? In HIF-RIF patients, contrary to HIF-RIF patients, heart failure with reduced versus to heart failure with preserved ejection fraction, this early dip and decrease in the AGFR was associated with increased mortality. So the HIF-PIF, the story is completely different. If just the AGFR is declining, stop the SARB. We don't have strong evidence here that SARB make a big difference here except for hospitalization. So it is haram to make the kidney to go for a medication that having a weak evidence in HIF-PIF. This is not in HIF-PIF, but it is in HIF-RIF. So regarding HIF-RIF and HIF-PIF, despite the prognosis of both are the same, they are not in the same boat. This is very important when using SARB according to the ejection fraction. This is, don't insist on this SARB or ARNI if the AGFR in decline. The story is completely different from HIF-RIF patients. If you believe in the king of mummies, they still use the ACE and R. If you just have a paradigm, this is 2014, this is not 2023, by the way. If you believe in this, then you face the ARNI, get less adverse kidney side effects. But after how long? 27 months. This is one of the big problems in the recent trials, which end up by 10 months follow-up. In 10 months follow-up, they will not catch the endpoints. So we need a long time for the ARNI to win above the ACE and ARB in the patients with heart failure. And this is again from the Paragon, and the Paragon was the HIF-PIF patients. And if you can see here that the early DFR should not defer the transition. So if you shift the patient from Divan 40 BD, Divan 80 BD, Divan 160 BD, I'm speaking about the AGFR at the edge, and then you convert it, and with this conversion, the AGFR have some dip, don't do anything. Wait and sustain this one, it will improve later. This is a very nice article for the people who are looking for the end stage. We need for the end stage that sacubitril valsartan, even in this patient, did a difference. This was a small trial. This was not still waiting for a big trial, but patients in him just look for the study population was already all in hemodialysis or peritoneal dialysis patients. Few slides in the spironolactone. The conclusion of this, I don't want to waste a lot of time. As long as the AGFR is less than 30, go ahead and add. As long as potassium less than 5, go ahead. But however, once the AGFR less than 30%, it is a problematic, and we said don't put now the MRA on board, wait for some time. And this is, for example, from the top cat for the spironolactone in HIF-PIF patients. If the AGFR is low, a lot of patients will discontinue spironolactone. So there is no need to put you under risk now and wait for the AGFR to improve. For the beta blockers, we have a lot of data that the 3 big beta blockers, I'm speaking about the carvedilol, the metoprolol, the bisoprolol, or decreasing mortality in patients with the chronic kidney disease. This is among all of them. But I will just want to, from your point, something important, dialysis patients. For me, carvedilol is the king. No way, carvedilol is the king. And any patients, especially with patients with having some black origin, carvedilol is the king for the heart failure. Data is very strong, but it may give you problems as a nephrologist. Why? Because if you go for the dialyzability here, carvedilol is the least. So if you are facing hypotension during dialysis, this drug is still there, and this drug will give hypotension to these patients. The best is metoprolol, is not available here in Oman, but bisoprolol is better than carvedilol in this patient. So if your patient having a variability in the blood pressure and having interdialytic hypotension, carvedilol is not the one to go. This is just the small difference to take into consideration when writing this medication. Now come to the now I start to face the same problem here. Now I discover what happened with you.
Okay.
Yeah, this is not working now. Go back and still I will still stop. Back. Okay. Okay. Now leave it to me. Leave it to me. Now come to the dessert, and the dessert here is the SGL2 inhibitors, the sweets for the kidney. At the end, we have a sweet for the kidney. At the end, we can do something, you can do something. I have seen it with patients, with some patients. I have seen it not even with heart failure, with only hypertension. The gliflozins make a big difference for the patients. Yes, I'm a fluoxinator, and I think all of you should be here as a nephrologist to be more fluoxinator even than me. So we said that the SGL2 inhibitors will inhibit sodium and glucose reabsorption at the proximal convoluted tubule, increase sodium chloride delivery to the macula, adenosine-mediated, afferent arterial vasoconstriction, reduction in EGFR. There will be reduction in EGFR. This is how the medication will work. And it will be -3, -5. And this one will take about 2 weeks. That's why we are repeating the EGFR after 2 to 3 or 4 weeks to detect the dip. And the DEB will recover up to 12 weeks, and it takes up to 52 weeks now for the curve to go up. So you should wait. You should be more patient with this is a life of a patient. When it comes to heart failure and kidney, this patient, his years is counted. So you cannot just because the EGFR came down from 60 to 50, you jump and stop. Wait, it will improve, but it can take up to 3 months to improve. So just wait for this. If no pain, there is no gain in such an issue. Again, the same problem. The EMBA used up to 20 EGFR. The DABA and SOTA, they used up to 30 EGFR. This is according to DABA HF, the Solwest, and the EMBA inclusion. This is just a very fast algorithm again for you when you treat. Number one, you check in 4 weeks after you start. If there is increase in serum creatinine by more than 30%, check for the volume status. If the volume is okay, volume depletion, stick for acidosis, check for acidosis. If there's acidosis, euglycemic ketoacidosis should be ruled out. If now there is no increase in the creatinine, you continue the SGL2 inhibitors. And then assess in 4 weeks. And then, if no volume depletion, you should try to rule out the other. As always, you are writing, stop the nephrotoxic medications and all of these things to this. And then you can again check the EGFR, and then again you can reinitiation. And then if there is no improvement, you continue, no improvement, you stop. If there is no acidosis, look for the diuretics. This is another big problem. Adjust the dose, and then you can go ahead. So this is how to go. So my last message is here is very important. Number one, this is a cardiologist without the kidney. You cannot go. You cannot go anywhere. You cannot go with ACS, you cannot go with anything, and you cannot go more important with heart failure. We hear that SGL2 inhibitors causing a DEB, the RNA causing a DEB, the MRA is serious, you cannot go with this one. The second issue, don't be, لا تكن أنت والزمان عليها. يعني the double jeopardy or the double jeopardy for the kidney and heart failure, you should not share this by preventing giving the guideline-directed medical therapy. You should sustain the dip. And I was telling a patient was coming to me, his EGFR was okay. Once I started, the EGFR declines. He came to me. أنا كنت جاي بس عندي مشكلة في الكلى، دلوقتي عندي مشكلة كمان في الكلى، أنت خربت الكلى، أنت تقول either you trust or go to another one. I have a lot of patients, not my, but you go another one. You should sustain, I should sustain. He said, I will sustain. It is improved in 1 month only. You should sustain the early dip. As a nephrologist, please don't forget about this cardiologist. Stop. Don't stop this one. The third one, this is the heart failure and the kidney. The fatal separation. The fatal separation. Thank you very much.
Thank you, Professor Mohamed. Get seated.